Good evening, Tarun. Thanks for the kind introduction. I'll share my slides. I think my slides are visible and I'm audible. Hi, Tarun, can you confirm? Am I audible?
Yes, sir.
Yeah, thank you. In the last 2 hours, we have seen very nicely that, similar to what we are seeing in other cancers like lung and breast cancer, targeted and immunotherapy have made their already way in the management of metastatic head and neck cancer. And also in the last clinical discussion, case-based discussion, we have seen that there is a lot of ambiguity while treating whether to use induction chemotherapy, whether to escalate or de-escalate. So this makes a way for more and more research to answer these questions, which patients, what is the optimum management for the given patients. So with these things keeping in mind, there is a lot of research activities going on, and recently also there were a good number of papers presented in the ASCO 2022, and organizers have selected these 5 abstracts to present. So they have given me this opportunity. I thank them for giving this opportunity to present these 5 studies presented at ASCO 2022. The first paper was nimetuzumab plus chemoradiotherapy versus placebo plus chemoradiotherapy in locally advanced nasopharyngeal carcinoma. Previously, a Tata TMS study in head and neck squamous cell cancers has shown that addition of nimetuzumab to 30 mg per meter square cisplatin has shown significant improvement in survival outcomes. That was in squamous cell carcinoma, head and neck cancer. However, this is nimetuzumab plus chemoradiotherapy in nasopharyngeal carcinoma. So, to set the background, the concomitant chemoradiotherapy increases survival in locally advanced nasopharyngeal carcinoma. Addition of nimetuzumab to radiotherapy was demonstrated to improve clinical efficacy in phase 2 studies in nasopharyngeal carcinoma as well. It is unknown whether the combination of nimetuzumab with CRT would provide a survival benefit. So the study design was roughly there were 483 patients of stage 3 and stage 4A nasopharyngeal carcinoma. This study was conducted in China. They were randomized in 3:1 fashion to nimetuzumab plus CCRT versus CCRT. The nimetuzumab was given 200 mg weekly, and chemotherapy was given cisplatin 100 mg per meter square Q3 weekly fashion. The primary endpoint of this trial was 5-year overall survival rate, and secondary endpoints were objective response rates, disease control rates, DFS, LRFS, and DMR. So if you look at the baseline demographics, I do not see any major confounding factors. They were almost well matched. To come to, since I have 5 abstracts, I will not go in detail. If you jump to results, definitely they met the endpoint that 5-year overall survival was in the 5-year overall survival in the nimetuzumab plus CCRT arm was 76% versus 64%. That is roughly around 11% improvement in the 5-year overall survival rate if you add nimetuzumab to standard CCRT with a p-value less than 0.05. So it is statistically significant. The addition of nimetuzumab to CCRT improved 5-year overall survival to the tune of 12.6%. So distant interstices-free survival, there was, if you look at the 3-year rate, it was 81.5% in the nimetuzumab plus CCRT versus 84.8%. Oddly 3% difference. At 5 years, again, it was 81.5 versus 84.8. If you see the statistics, it is just stopping at 0.5. It is not less than 0.5. So if you look at the toxicity, we know that unlike other anti-EGFR antibodies like cetuximab or panitumab, nimetuzumab comparatively relatively safer. If you look at the toxicity profile, even if you look at the oral mucositis, that is a dreaded complication we expect with addition of nimetuzumab. However, this is a nasopharyngeal carcinoma, not oral cavity carcinoma, where mucositis is a big concern. But in this trial, it was almost similar side effect profile. So the authors concluded that nimetuzumab combined with chemoradiotherapy in the treatment of locally advanced nasopharyngeal carcinoma had a better efficacy with a 5-year OS rate increased by 12.6% with 36% reduction. Complete response rates increased by 13.3%. So, and also it has a good safety profile. But one caveat to this trial is, we all know that in nasopharyngeal carcinoma, there is a role for either induction chemotherapy or adjuvant chemotherapy. However, in this trial, both control arm and in the nimetuzumab plus chemotherapy arm, there was no either induction chemotherapy or adjuvant chemotherapy. So that's a second trial, again in the nasopharyngeal carcinoma, in intermediate risk factor. Do we overtreat them by adding CCRT, or should we just go with the radiation therapy? So this was the hypothesis for this trial. This is again a randomized phase 3 trial. Previously, the previous trials which established the role of CCRT, they were in the era of pre-IMRT. The need for concurrent chemo was to improve the radiosense, make it improve the reduce the radiation dose, so that good locoregional control is added by adding the concurrent chemo. However, the hypothesis is that in the IMRT era, probably we are achieving a good locoregional control without chemotherapy. So should we omit chemo? That was the rationale behind this question, study. The inclusion criteria was non-keratinizing type squamous cell carcinoma T1, T2, N1 or T2, T3, N0, that is stage 2, or T3, N0 squamous cell carcinoma, non-keratinizing nasopharyngeal carcinomas. So the harms were either IMRT 66 to 70 gray with SAB planning, or along with cisplatin, that is administered again 100 mg per meter square in 3 weekly fashion. So the primary outcomes, that was FFS, they did not reach the barrier of inferiority. In intent to treat population, 3-year failure-free survival was 92.2 versus 90.7%. Though there was numerical benefit, it was not breaching the inferiority margin. And even at the per protocol, 3-year FFS was 92.1 versus 19.7%. If we look at the secondary outcome measures like 3-year overall survival, 98.7 versus 99.9. 3-year distant metastasis-free survival was slightly lower in the non-chemotherapy arm, that is RT alone arm, the 95.6 versus 98.1. However, it was not statistically significant. So if you look at, however, if you look at the toxicity profile, we all know that if you add a concurrent chemotherapy, definitely it adds toxicity to the patient, either in terms of vomiting, anorexia, mucositis. All these are much more significant if you add concurrent chemotherapy. So this trial, though established that IMRT is maybe a single modality, RT in the era of IMRT may be a non-inferior to concurrent chemoradiotherapy, but it is a single trial. So as of now, still NCCN continues to suggest concurrent chemotherapy. Probably this throws a light that probably in a few patients where concurrent chemotherapy is not feasible, in such patients, this is not a bad option. So another trial, we all are in the era of molecular. Now we are now moving from the times of imaging to follow up patients to molecular, something like circular tumor DNA, to predict recurrences, to follow up responses. We are all moving to that era. This is one trial similarly looked in the head and neck cancer, the association of plasma tumor tissue modified viral HPV DNA. How does it correlates with the tumor burden, treatment type, and also outcome. So this is already the trial was looking at the role of IMRT alone versus concurrent chemo plus IMRT. In this trial, they also looked at the role of this tumor modified viral DNA. How does it correlate with the tumor burden and also treatment responses and outcome? So they collected this blood samples at 3. One is pre-treatment. Second one is T1, that is timeline 1, that is at intra-treatment, that is somewhere between when patient has received some roughly between 20 to 28 gray of radiations. And the third point is T2, that is 2 weeks to 1 month post-treatment. So they defined this tumor tissue modified viral as a positive if it is more than 5 fragments per ml. If it is less than that, it is considered undetectable. Whenever it was undetectable, they also looked for other HPVs like HPV 18, HPV 31, HPV 33, HPV 35. So this timelines already we discussed. So they suggested that if pre-treatment, if it is higher TTMV, does it correlate with the T and N stages of the disease? And intra-treatment drop, does it shows any difference between the treatment modality? One arm was radiation, another arm was CCRT. And the post-treatment, if undetectable, does it predict the better prognosis? So in this trial, they could collect roughly around 53% of the patient donated at least one sample, and first sample was collected in 53%. Second sample was collected in 2 samples were collected in 45%, and 3 samples were collected in 42% of the patients. So if you look at the about 10% of the P16 positive patients had a 0 TTMV fragments, that is tumor tissue modified viral DNA fragments, were not detected in roughly around 10%. Among those who were positive, 6.6% had other types other than HPV 16. So their first hypothesis was to correlate whether this baseline TTMV fragments level correlate with the T and N stage. Yes, they showed that if you look at the T1 to T3, it is slightly increasing. It is not a strong correlator. It was weakly to moderately correlating with the T and N stage. If we can look at that, the fragments levels are increasing at T, and also it is increasing as burden of nodal burden is increasing. And the second hypothesis was, does this differ between the treatment arms? So the red line was in the CCRT and the blue line was in the RT alone arm. If you look at we all in the breast cancer we see that we do not have to wait for the EFS or OS to determine whether the neoadjuvant therapy is approved or not. Just based on PET-CR, nowadays we are getting approvals. So similarly, can we use this biomarker that if the fall can be a detrimental, can predict the efficacy of a treatment? They looked at it. In CCRT, there was a significant drop. However, on the radiation therapy, at T2, at T0 to T1, that is somewhere between 20 to 28 fraction, there was not much difference in the TTME fragments. And the third hypothesis was end of therapy TTME fragments, whether detectable or not. This showed that if it is not detectable, definitely it predicted a very good survival outcomes. That T2 undetectability rate was roughly around 93%, and fragment clearance rate was roughly around 95%. So we can see that it has a very good in those who had a negative TTME. It has a 95% local regional failure rate. They did not fail at 2 years, and also progression-free survival was 93% in those who had undetectable. Those who had a positive, a majority of them had roughly around 25% of the patients had a progression at 2 years. So to conclude, the feasibility of roughly around 10% of the P16 positive patients had 0 detectability at baseline. So majority of the patients do have a possibility. So it is applicable for majority of patients. Among those with a clearly detectable TTME, 6.6% had other types other than TTME, HPV 16. T and N stage were weakly to moderately associated with higher pretreatment fragments. IMRTC arm achieved a more rapid decline. So probably in the coming era, we do not have to wait for EFS, probably use these markers as a response to therapy. And the negative predictive value of post-treatment undetectability was 93 to 95% for 2-year loco-regional failure and PFS, and a clear detectability was associated with a 1 in 4 patients having a PFS event. Similarly, what we are seeing ctDNA in other cancers like colorectal, lung cancers. So the fourth abstract is results of phase 2 multi-center study of IMRT re-irradiation with concurrent or adjuvant nivolumab in patients with loco-regionally recurrent or second primary head and neck squamous cell carcinoma. We all know that majority of squamous cell carcinoma patients who are treated with radiation do recur. and some of them recur loco-regionally. So they still may be amenable for a salvage therapy either in terms of surgery or re-irradiation. However, if you go for re-irradiation, how do we improve the outcomes of these patients? We know that nivolumab or IO therapies have made their way already in the management of advanced squamous cell carcinoma, either in recurrent or metastatic setting. So can we bring this in the curative setting also in the recurrent stage? This paper looked at that. To assess the this is a single arm trial. They looked at the 1 year PFS for patients with recurrent or secondary primary head and neck squamous cancer treated with IMRT re-irradiation with concurrent and adjuvant nivolumab. So it was multi-center study. They basically gave a re-irradiation to the dose of 60 to 66 gray. Nivolumab was given 2 weeks prior to initiation of radiation, then at 0 to 6 weeks, followed by 10 week, beginning from 10 week, IV nivolumab was given every 4 weeks. That is monthly dosing of 480 mg up to 10 courses. So 10 months of adjuvant nivolumab was administered in this. Inclusion and exclusion criteria was similar to what we consider for re-irradiation. And if we look at as of January 2022, a total of 51 available patients completed IMRT with Nivo. Median age was 62. Roughly 80% were male. CCOG performance status P16 positivity was seen in 31%, and median follow-up of this study was 12 months. So we can see that PFS achieved, median PFS they achieved was 14 months in the recurrent setting with re-irradiation, and 1 year PFS was 60%. Median OS was 19 months with 1 year OS rate of 82%. And toxicities were almost manageable. Grade 3 and higher toxicities were seen in 51%. That is expected in re-irradiation, particularly when IO is also added. However, immune-related like colitis, infective myositis, or myasthenia gravis, they are all to the tune of single digit, that is 2 to 3%. So this trial concluded that it met its primary endpoint of 1 year PFS, that is of more than 50%. IMRT re-irradiation with concurrent and adjuvant neo is clinically effective. Probably this plays a role for further randomized trial to see whether addition of nivolumab does any benefit to if added in a curative setting too. We have seen a similar abstract with pembrolizumab also in the first line setting with CTRT. There again, it was not a RCT. So probably in the coming future, these trials similar to what we had seen with durvalumab in the post-CCRT setting in lung, probably we may see in head and neck cancer also addition of IO to CCRT or in adjuvant fashion. And my last abstract for today's talk is that is from our own country, that is from Dr. Atul sir. This study was again a multi-center study, majorly involving AIMS and Army Hospital, R&R Delhi. So there was a lot of dilemma and ambiguity. Should we use 100 mg per meter square or 40 mg per meter square? Majority of the centers do, I agree that they go for 40 mg per meter square cisplatin weekly even before this trial. But there was no any evidence to suggest in a definitive setting, does it make, is it non-inferior or is it inferior? This answer was not available. Previously, as the previous speaker mentioned, 30 mg per meter square did not meet the benchmark. So there was ambiguity, does 40 mg per meter square also fail? So this was addressed by this AIMS trial. Already previous speaker has highlighted this. I'll not go much in detail about this. So all the other factors were similar. They tried to look at, their primary objective was 2-year loco-regional control rates, and secondary objectives were OS, PFS, and grade 3-4 chemotherapy related toxicities. So in the standard arm, it was given 100 mg per meter square, 3-weekly fashion, total of 3 doses, and cisplatin in the experimental arm was 40 mg per meter square. We know that at least 200 mg per meter square should be given. So we have a 7 weeks to administer. So at least if we administer 5 doses, we achieve the 200 mg per meter square mark. Whereas for 30 mg per meter square, we need to give all the 7 planned cycles to achieve the 200 mg per meter square mark. That is where the story lies, I believe. So roughly around 403 patients screened and 278 finally randomized in 1:1 fashion, 137 to standard arm and 141 to test arm. And baseline characteristics, if you see males, females, and P16 positivity, they were all properly balanced between the two, and even the ECOG PS, they were properly balanced. Moving to the clinical response, if you look at the objective response rates, so the CRs were achieved in 53% in the standard arm versus 61% in the weekly arm, with a p-value less than 0.05. There is a roughly around 8% improvement in the CR rates, and PRs were again 29 versus 25. So there is a slight increase in CR rates by weekly. And if you look at the radiological responses, here the responses were 69 and versus 72%. So radiological response were not statistically significant between either if you go for 100 mg per meter square or 40 mg per meter square. And the primary endpoint was 2-year loco-regional control. So it was 56% in the standard arm and 60% in the weekly arm. So it was non-inferior to the standard arm of 100 mg per meter square. The median OS was also 30 months versus 25.5 months. Again, it was non-inferior. And if you look at the other markers like median time to local regional failure, median OS, median time to LRF, they were almost all similar. There was no across all these benchmarks, it was non-inferior to the standard arm. However, if you look at the toxicity, we can see that whether it is either mucositis, it is 54% versus 40% in the weekly, or if you look at the myelosuppression, again, there was a doubling. If you look at the renal impairment, it was almost six times more in the 100 mg per meter square compared to weekly fashion. And even the dermal reactions, vomiting, they were all higher in the 100 mg. So this suggests that 40 mg per meter square is much more safety profile point of view, is much more feasible compared to 100 mg per meter square, and we do not lose efficacy by doing so. So the CONCERT trial confirms the cisplatin in the dose of 40 mg per meter square weekly is non-inferior to cisplatin 100 mg per meter square weekly along with RT as a definitive treatment. It is better tolerated, as a better toxicity profile, results in a less supportive care needs and hospitalization. So finally, it may reduce the economic burden on the patient too. Concurrent weekly cisplatin in the dose of 40 mg per meter square also should be considered as standard treatment option whenever definitive CT-RT is planned. With that, I conclude my presentation. I hand it over back to the organizers. Thank you.